automatically once that's doing that. Still doing.
Okay, and are you able to?
Let me see. Oh, I can. Oh, yeah, I can. If I click on it, that changes for you, does it?
Okay, yeah, it changes for me.
Perfect.
Okay, I will keep an eye on the chat then and answer any questions that come up.
Amazing, thank you. Yeah, I think that sounds great. Let's just wait for people to join.
3 minutes.
Yeah, we've got some people already here, I can see. So we'll just give a few minutes and then hi everyone who's already watching. We'll give a few minutes, let people join, and then we can start.
If you could just let us know if you can hear us, just so that we're not we're not accidentally just talking to ourselves. Just like a yes or a thumbs up would be really appreciated. Deadly silence. Okay, that is reassuring. I'll put something on the chat.
Oh, also, those of you who are here already, if you feel like you have a spare minute, if you don't mind scanning the QR code, there's a little survey that we're doing at the moment. If you could spare us a few minutes for that would be great while we wait for the rest of you guys to join. We're just going to give 1 or 2 more minutes and then we can get started. All right, I think let's get started. Aaron, do you mind just muting yourself for the moment? Because I think I can hear an echo. Thanks. All right. So, hi, everyone. My name is Millie. I'm one of the F1 doctors working in East London at the moment. And yeah, I'm currently working in psychiatry and I'll be doing a session today on the PSA. And I've got Aaron with me. Aaron, you can say hello as well if you want to. Unmute yourself for that if you want to.
Hi, good evening all. My name is Aaron. I'm one of the military FY1s currently working at in the Northeast. I'm on vascular surgery. So prescription review and ADRs, that's just something I do almost every day. I'll just be monitoring the chat and doing some polls and things for you guys to get some interaction. Thank you for joining.
All right, let's get started. So this is our third session of our PSA series that we're doing at the moment. So we're going to be focusing on prescription review and adverse drug reactions, two of the sections that are covered in the PSA. So with prescription review, we want to really ensure that you can systematically review them. As Aaron said, it's something that you'll do on a day-to-day basis as a doctor as well. Things to look out for would be things like dosing errors, contraindications, withholding medications, and nephrotoxic medications. And in adverse drug reactions, again, being aware of some kind of drug reactions that are fairly common, being aware of interactions with drugs itself, the side effects, toxicities, and how to treat adverse drug reactions as well. So we're going to start by talking about prescription review. Prescription review is, after the prescription section, your second biggest review. You have usually 8 items, and it comprises 32 of the total of 200 marks. In terms of how that would break down in terms of the time you should spend in a minute, would be 2.5 minutes per question in the exam. You might find that you will need a little bit more time or less time depending on how fast you are, but suggested would be spending around that much time per question. So yeah, this is on the top. You can see a picture of what your prescription review would look like. So there you'll have a relatively brief case stem, usually what medications they're on, any examination findings, any investigations. Often it's comprised of 2 different parts. So you can see question A and question B. So, for example, in question A, which drugs are most likely causing the hematemesis? And in question B, which drugs are most likely contributing to the impaired renal function? So you'll have to think about the same amount of drugs twice, if that makes sense. And then you just click them. Always make sure that you look at how many prescriptions they want you to review. So they could ask you to look at 1 or 2 or 3 different ones. So make sure you read that very carefully. And yeah, that's pretty much all on the format of prescription review. We're going to do some questions now. So we're going to spend time doing 5 questions in prescription review. So question 1, I'm going to read it out. It's quite short. So it's a 33-year-old woman. She comes to the GP with palpitations. She, as part of her workup for the palpitations, she has an ECG. In terms of her past medical history, she's got recurrent thrush, she's got hypothyroidism, and she's got depression and anxiety. Her drugs are listed below. There's no known drug allergies, and her ECG I've just summarized for you guys. So it's sinus rhythm, rate is 68 beats per minute, PR interval is 0.12 seconds, the QRS is normal, so less than 120, and the QTC is 0.52. So my question for you guys now would be, which drug is most likely responsible for these ECG findings? I'm going to give yourself around 2 minutes, and try and use the poll if you can. So you can click away on the poll and then click back to it via the chat as well. Okay, keep answering. I can see 6 responses already. Sure. Don't know if you guys saw that. I'll just keep it going for a second. Again, one thing I should have probably mentioned, feel free to use the BNF for this. You can use the BNF in the exam.
Yeah, for these kind of questions, I was just saying to Millie at the start that my Control F key just started to kind of light up. Yeah, but if you're familiar with the kind of common side effects, then it will just speed you up. But if in doubt, yeah, you should have the BNF up on one side and then the question on the other in the real exam.
Yeah, we can talk a bit more about the practicalities and how you would do that. There's different options how to do that, but we can talk about that afterwards as well. I'm just going to give you guys 20 more seconds. All right, I think in the spirit of time, we're going to keep it at that. So, as I unfortunately already revealed the answer earlier, so if we look at the question, we need to identify what is actually the abnormality in this ECG finding. So the QTC in this case is elevated. So QTC roughly should be around 450 milliseconds. In this case, it's elevated quite grossly. And the drug that's responsible for that is most likely fluconazole. So well done to the 29% of you that got that right. Well done. I'm going to tell you now how you would easily find that, because most likely you're not going to know that fluconazole causes QT elongation. So there is a really useful table called Appendix 1, which you guys might have been familiar with. Appendix 1 has all the interactions that well, it has a really good list of interactions, such as things causing hyperkalemia. It also has a section on drugs that prolong the QT interval. So if you've already identified that the QT interval is long, you can then look at all of these drugs. As Aaron was saying earlier, Control F is a really good thing as well. So you can skip to QT very easily if you click on that. And then equally in QT, you could look for the drugs individually so that you don't have to read through the entire list of this. And yeah, fluconazole is a drug that causes QT elongation. So fluconazole is the right answer for this one. You can also find it, so sometimes it's not listed in this, so you could also look up the individual drugs and then look at the cautions, for example. So you can see on the bottom, this is what the screenshot from fluconazole. And it says that there's anyway, it can cause QT prolongation, QT interval prolongation. So that's another way how you could have gotten there. Anyway, so two different ways, basically. Someone's saying listed as a common side effect under sertraline and SSRI. Let me have a look at that as well. If that's the case, then I do apologize. I try to avoid these questions myself. So if that's the case, then yeah, well done for finding it out. I will have a look at that, or maybe Aaron, if you could have a look at that, and we'll pop the answer to the chat. If that's the case, maybe both of these answers would have been successful. So yeah, any other questions, or we'll move on for now? We'll come back to that with the sertraline afterwards. And question number 2. So we have a 70-year-old gentleman. He's just been clocked by the on-call doctor, and your goal is to review his drug chart. He had a MI 2 years ago. He's got now ischemic heart disease, and he's got hypothyroidism. He is taking all the medications at the bottom. He has a penicillin allergy where he gets a rash. And your job is to select the 2 drugs that most likely contain a serious dosing error. And I'm going to give you 2 minutes again for that. And some of you are very quick at this. if you can only select one drug, that's fine. Just select one drug and think of the other ones for yourself. I don't think there's an option to do that on metal, unfortunately, for 2 pearls, but that's fine. All right, I'm going to leave it at there. Last chance to answer now. So, majority of you are bang on right. So, the important information, I guess, in the stem in this one would be that he had an MI 2 years ago. And that would indicate that his atorvastatin should be on 80 milligrams, primary versus secondary prevention. And then the other very commonly drug that's involved in the PSA is levothyroxine. Levothyroxine is prescribed in micrograms and not in milligrams, and this is a common mistake that you might find in the PSA, essentially. So A and D, well done to answering that, would be your correct answers. Now, if you don't know this by heart, which a lot of you won't, this is how you would go there. So there's a lot of things like levothyroxine, I would advise just know. There's a few drugs that are prescribed in magazines. However, you can also just look up the drugs themselves. There's only 5 drugs in this available, so you could look them up and then look at the dose. So I think at the left you can see the levothyroxine, and it says that it's prescribed in micrograms, so that's how you would get there. In terms of the atorvastatin, again, knowing primary versus secondary prevention doses is quite key in this case. And then if you go on indication and dose, you can see that they should be on 80 milligrams once daily as opposed to the 20 milligrams that this gentleman was on. So yeah, always check for units, definitely, and know some of the common drugs and doses. So things like you want to know your beta blockers, you want to know your antihypertensive medication roughly in a range. It will just help to save you time. All the information is there on the BNF, but it will help you to save time. All right. Right, question number 3. So we have a 40-year-old gentleman. A few days ago, he went to A&E. He was vomiting blood. He's now in hospital. He's got pneumonia. In terms of his past medical history, he's got a gastric ulcer, he's got high blood pressure, and he's got diabetes as well. He's got his drugs are below, and he's got a penicillin allergy, as a lot of patients do. He's anaphylactic against it. You've got his OBS below. So in this case, which drugs are most important to stop in this patient, in this situation at the moment? So again, thanks for putting two polls in there, Aaron. So there's 2 polls for you to answer. You can go one on each. Yeah, I'll give you 1.5 minutes again. Okay, you can see some great answers. Keep answering. right, I'm going to leave it at that. So, two important things in this case. I noticed that when I was reading it earlier, it's maybe not quite clear, but this patient he came to A&E with vomiting blood. He's not currently vomiting blood. I apologize if that was unclear. However, his blood pressure is very low, or sort of coming into a shock blood pressure, not quite by definition, but definitely low. Also, he's allergic to penicillin, yet he has been prescribed a antibiotic that has a potential reaction of cross-reaction, a cephalosporin. So we need to stop the cephalosporin due to a cross-reaction, allergy reaction with penicillin. And we also need to stop his blood pressure medication because his blood pressure is low, so there's no need. Arguably, the blood pressure stopping medication, arguably he might have had it today already, but definitely it should be temporarily withheld given the clinical situations because he's unwell. So that's why you would stop that. There's not really any indication to stop any of the other drugs as far as I'm aware. The tranexamic acid, there's no indication to stop this. Metformin, there's no information from what we have to stop this either, and neither is for the atorvastatin. Yes, they're not as crucial in this moment, but we should definitely keep them all going. So the most important ones to stop would be those two. Now, again, how would you, if you don't know this, just by looking at the question, how would you solve this? So always check allergies and, yeah, always just look up the medications as well. It is actually, if you go on allergies and cephalosporins, and that it will actually be there, that there is on the BNF, that there is a hypersensitivity reaction in a fair amount of very few number of patients, but it is there, so you should not forget that. And then again, observations are very crucial when you review a prescription. That's the one thing that I think I was highlighting earlier, that's something that as a doctor you will do this day in, day out, reviewing how their vitals are. And you should be able to recognize that if they have a blood pressure drop, you should at least withhold all medications that could potentially make the blood pressure worse. So things like nitrates are quite commonly contraindicated if someone has low blood pressure. Any blood pressure medications, if they're bleeding, any medications that could encourage that bleeding, things like warfarin, any blood thinners, you need to stop as well, things like that. So that's how you would answer that question. Again, in Appendix 1, there is a table that's drugs that cause hypertension, and you can look at that as well. So if you are unsure if a drug can cause hypertension, this is where you would go for. But most of these are antihypertensive medications in all fairness. So yeah, that's how you would answer that. Moving on. So question number 4. So we have a 28-year-old woman. She comes to A&E and she has a sudden onset of right heel pain, or left, let's say left heel based on the picture, left heel pain. In terms of the past medical history, she's got PID, pelvic inflammatory disease, very recently. She's also got hay fever and she's got fibromyalgia. Her medications are listed below. She's got no allergies. And when you examine her, she is limping from her left foot and she is visibly in pain. And then her left heel looks like this, so it's bruised and it's swollen and it's quite poorly defined. So my question would be, which single drug has most likely caused her symptoms? So I'm going to give you 2 minutes again, or 1.5, see how far you get.
So without giving away the answer, we've actually seen that there's been a growing movement on social media about this specific side effect.
I saw that as well, actually.
Yeah.
I saw that reel.
And I'm not sure if it's Instagram calling me out as a massive nerd, but I just thought I'd point that out. And there's also been just campaigns on the wards that I've seen for the ward pharmacists to just ask us to review if we're going to prescribe this drug, essentially. To watch out for these side effects.
Definitely an adverse reaction to be aware of. Yeah. When I made this question, it was before I saw all of those videos on social media. Actually, it was not prompted by this, but it is definitely good to be aware. Because as doctors, we should always aim to do no harm. Unfortunately, all of our medications will have side effects, but we should definitely be aware of that. All right, I've got loads of responses, so well done. You guys are very fast. And very good, apparently. So yes, so as seen by the picture, you've got sort of that poorly defined heel, and the pain, quite sudden onset, which would indicate a Achilles tendon rupture. Again, you could talk about, all the tests like Simmons tests and things like that when you can test the Achilles tendon itself. And then the drug that's most likely associated with that is moxifloxacin, which is a type of antibiotic. So again, this is sort of a very odd one to know, but I think it's a very important one to know. And again, the same principle apply that if you don't know, you could look up the drugs individually and look at what could be causing that. So if you've already kind of deduced from the stem this is an Achilles tendon rupture, but you're not quite sure which medication could be causing that, you could look at, so you can either actually look at, if you see in BNF, I put in tendon rupture on the top right, and then it comes up with moxifloxacin almost on second answer, as it comes up as a side effect there. So that's one thing to look out for. But if you can't do that, or if you can't figure anything, you can go in the drug itself, and then you can look at the important safety information or the side effects. You can also use Control F, and you can search for key phrases like tendon rupture or MSK or or pain, anything that you could think that it would most likely come under. You can look for that, and then if you don't know that quinolones cause that, that's how you would find that. That's pretty much all there is to say for that. Okay, let's move on to question number 5, which is our last question for this section. So we have a 55-year-old patient. They have routine bloods. They've got gout, rheumatoid arthritis, type 2 diabetes, and ischemic heart failure. The drugs are listed below. They have no known drug allergies. Now, in terms of their investigations, the investigations today, the GFR is 35, but 2 weeks ago, the GFR was 80. So I just put there that's an AKA stage 2. So in light of this blood test, which drug would you most likely stop? I'll give you guys 1.5 or 2 minutes, see how far you get. I'm just giving you guys a little bit more time. I know that's quite a lot of drugs to look up. got a few responses. So I think I'm going to keep it at that. So essentially what this question is asking you is, we've got this patient with renal impairment, acute renal impairment. GFR is 35 at the moment. Which drugs do need to be stopped? So there's some mnemonics on, I think there's something worth remembering, which drugs should be stopped if we've got renal impairment. So the answer for this question today would be ketoprofen, methotrexate, and spironolactone. All right, and we're going to go over why these medications and why not the other ones should be stopped. All right, so there's a few potentially nephrotoxic medications in this set. All right, what you could do is you could go on Appendix 1. There is a lot of drugs on there that could cause nephrotoxicity, so that can give you a little bit of a screening action. There's some drugs that you might know by heart. So, for example, NSAIDs. I think a lot of people are aware that we need to stop them. And yeah, it might be worth looking up the individual drugs in this case. So, for example, I believe this on the right side is for metformin. So with metformin, you should only avoid it if the eGFR is actually less than 30, according to the BNF. I know that often it would still be stopped, but according to BNF, it's only indicated if your GFR is less than 30. So it's always worth looking at what is actually the GFR in this case. There's a mnemonic called, I think it's called DAM, so it's diuretics, ACE inhibitors, ARBs, metformin, and NSAID, that's in it. But then I think there's sometimes different mnemonics as well that to cover as many drugs for that as well as available. But I would just point back to Appendix 1. With renal impairment as well, there is a lot of subsections on each individual drug that you can use. Again, if it says caution, so I'm aware that some of the drugs just say caution may adjust dose. If there's no other drugs, you might want to caution that, but there's some drugs that specifically say stop, do not use. So those will take priority over something. For example, I know that some of you said allopurinol. With that one, we just need to be cautious, but definitely it's not the most important one to stop, if that makes sense. So yeah, hope that was clear. I'm going to move on to the next section now, which is adverse drug reactions. Obviously, any questions, feel free to put them in a chat, and we can answer them from there. And we can also go back at the end of the section as well. So, adverse drug reactions. So we've covered them a little bit already, actually, with the quinolones. So there's 8 items in the PSA. Each will be worth 2 marks, so 16 marks in total, which is not a lot. However, it's quite straightforward. It is suggested that you spend around a minute per question, which is not a very long time. So it's very good to know if you have a good base knowledge of adverse drug reactions, of common drugs, and maybe interactions as well. Because you will be pressed for time if you have to look up every single drug for this one. Similar principles, so you're going to have a stem on the left side, you might have some investigation findings, you might have some observations. There's going to be a question which usually says, oh, which drug causes this? And then you're going to have some options and select one. So that's that. Let's do some questions. So we have a 55-year-old man. He's been prepped for surgery. He's got regular medications. During surgery, the anaesthetist is considering to use propofol. So which of his regular medications is most likely to interact with propofol? I'm going to give you guys a minute, I think, on this. All right, I think I'm going to keep it there, trying to keep it nice and brief. So, the majority of you are right. It is verapamil. I'm just going to go over why that's right and why the people who said D are potentially also right. So, if we think of the drug classes, propofol is a beta blocker, verapamil is a calcium channel blocker. They interact with each other. They can cause bradycardia and hypertension. In terms of why I think sodium valproate is the less appropriate action, but nonetheless worth mentioning, if you go on the BNF and look at the interaction between sodium valproate and propofol, it says that there is a severe reaction, but it's theoretical. So if you have possible theoretical interactions that you see on the BNF, that should go lower than an actual interaction that's documented and that's well known. So I agree that it's not the most straightforward, but theoretical will go rank less or lower than an actual interaction, if that makes sense. In terms of how you could find this out if you're not aware of it. So you could click on the drug itself. So we know that it has to interact with propofol. So you can click on interactions of propofol, and then you could control F and look for all the drugs if you wanted to. If you are using Medicines Complete, which hopefully a lot of you are aware and I would encourage to use, there's also the interaction checker. Now, I know that it's not, some people are not quite sure if the interaction checker is working in the PSA. The answer is I don't have the answer for that either. They change it all the time, but I would definitely recommend spending a little bit of time on getting to know the additional features on Medicines Complete in case they are available. The interaction checker on Medicines Complete is amazing. You can just pop in all your drugs. So you could pop in all your 6 drugs all at the same time, and it will come up with a list of the drugs, and it will rank them as well. And then you can look at them, and it will save you a lot of time, especially if there's a lot of drugs that you don't know. So yeah, that would be 2 different approaches on how you could potentially figure out this. So I hope that makes sense. Any questions, as always, in the chat, happy to answer. And we'll go on to the next question. So we have a 40-year-old woman, and she's come with a new onset of irregular periods. She's got her regular medications are below. So my question for you would be, which drug is most likely to be responsible for her symptoms? And you have 1 minute. All right, and that is 1 minute done. So, well done to the majority of you. You got it right. So we've got irregular periods, most likely be caused by a progesterone-only pill, which is diacetyl. I can see that some of you also answered D and C, and I'm going to go over why that isn't the case. Because both, I think, from memory, can potentially cause irregular periods as well. So again, how would you find out about this if you don't know? So I think it's worth knowing that diacetyl is a progesterone-only pill, and the common side effect of that one is irregular periods, as opposed to the combined pill, which has regulating effect on periods. If you go on diacetyl, if you look up the drug itself, under common or very common side effects, it does say menstrual cycle irregularities. Again, I would recommend using Control F, because side effects, there's a lot of them, and if you have to read through the entire section, you might run out of time. So if you just Control F and then go with menstrual or something like that, it will highlight it like it did here in this case. I believe that the one on the bottom now, I think that's the one for risperidone potentially that I copied. So you can see that for desosterol, it's a common or very common side effect, whereas for this drug, frequency not known, which usually means very low frequency for the drug, which means that if you want to determine which one is more likely, it will have to be the one that has a higher frequency of the side effect. All right. On Medicines Complete, again, there is something called the Adverse Drug Reaction Checker as well, where you put in your drugs at the top and you can put in the reaction that you're looking for. Again, this is something that's, again, query if this is available on the PSA. I would recommend checking it out if you haven't already. It can save you a lot of time if you know how to use it, but I would not rely on it in case it isn't available for the PSA. But it's definitely a very good tool to play around with and have a look at it, basically. So yeah, that's that question. Moving on to question number 8, we have a 55-year-old woman. She's meant to be started on warfarin. She has epilepsy and she's got tinea pedis, and she's a recent TB contact, which is why she's taking all of the below medications. She doesn't have any allergies. Now, which of the drugs is most likely to interact with warfarin to cause an increased INR? I'm going to give you guys a minute on that. All right, and that is time. Well done if you who managed to answer in time. So I think this is a bit of I purposely made a bit of a mean question, because all of these drugs are going to interact with warfarin. However, the question was which one can cause an increased INR? The answer to that is fluconazole. Well done to the majority of you, got that right. The thing with warfarin is that it's a very common substrate of your CYP450 enzyme. All of those drugs that I've listed below are examples of inducers/inhibitors. So you first need to identify, I'll be looking for an inducer and inhibitor, and which one is it out of those. All right. So remember that your CY4P metabolizes the drug. Which means that if you inhibit the P450, you get higher drug levels because you have less of the enzyme that gets rid of the drug, meaning more drug. If you have an inducer, you have more metabolism leading to decreased levels. So it sounds a bit contradictory, actually, at least to me. So while remembering that, there is some mnemonics that you know in terms of remembering the different ones. So I think a common one and good ones for inducers would be crap GPSs. So you've got your carbamazepine, rifampicin, alcohol, so that's chronic alcohol use, phenytoin, grisealfomin, phenobarbital, sulfonylureas, and St. John's wort. Inhibitors is sickfaces.com, so you've got sodium valproate, isoniazid, cimetidine, ketoconazole, fluconazole, amiodarone, and also acute alcohol, chlorophenicol, erythromycin, sulfonamide, ciprofloxacin, omeprazole, and metronidazole, and also grapefruit juice, which I couldn't fit into the mnemonic anymore. So yeah, and then your substrates, again, it's well worth knowing some of your substrates. Warfarin is a common one. Statins potentially have some ones as well, but I think usually it'll be one of those, or maybe phenytoin as well. Also, I know that phenytoin is mentioned twice in substrates and inducers. I tried to look up the answer of that, and I'm still not sure why that is. I don't know, Aaron, if you had any suggestions on that, but if you look it up, it's listed on the both. I do not have the answer for that. But yeah, anyway, so we're looking, in this case, we're looking for an increased INR, which means we want more of the drug of warfarin, which means we want an inhibitor, which in this case was our fluconazole. So yeah, that's how you would get to the answer. Again, you could also look at the interaction checker and put all the drugs in there, and then look what it will do to you. But I think in this case, quite important to know your enzyme inducers and inhibitors, and well worth remembering them for at least the exam, I would say. And yeah, that's that question. So we've got two more questions. We've got question 9. We've got a 29-year-old male. He's an inpatient on a psych ward. He's now very drowsy, and this is quite untypical for him because I saw him 2 hours ago and he was incredibly aggressive, and he was threatening to staff, and he was hitting chairs, and he had to be restrained. He's got a past medical of his schizophrenia. That's why he's here. His regular medications, so he's on clozapine once daily, and he's on lorazepam PRN. He's also on paracetamol PRN. He doesn't have any allergies, so you examine him. So he's drowsy. You see nystagmus when you look at his eyes, and his respiratory rate is 6. So my question for you would be, what drug should we give him now? I'll give you 1 minute. Oh, flumanicil is taking a lead over naloxone now. Interesting. All right, last seconds. And that's time. So, well done. So, again, I think this is a bit of a mean question from my side. Definitely the two differentials that we're looking at would be an opiate overdose or a benzodiazepine overdose. Both can result in the patient being quite drowsy and respiratory depression. There's two key factors that I think are differentiated too. So nystagmus is more commonly seen in a benzodiazepine overdose as opposed to an opiate overdose, which will have pinpoint pupils, very textbook-like. Also, this patient is not on any opioids. He's only on paracetamol, 1 gram, and he had to be restrained, suggesting that his lorazepam was probably used recently, and he might have had a bit too much lorazepam or reacted back to it. So lorazepam, benzodiazepine overdose. The antidote for that one would be flumanicil, 200 micrograms. If you don't know flumanicil as the antidote, which is fair enough, there is a treatment summary called poisoning, which is actually a very good one. I would highly recommend being aware of that one. There is all the drugs that you can see on the left side, all the different overdoses that you can think of, things like lithium overdose, I think paracetamol overdose, snake bites, things like that. And you can just go to your section. So if you go on your benzodiazepine sections, it will say that charcoal can be given within 1 hour. It's now 2 hours, so charcoal can't be given. And then it says that flumacenil can be given as well. I know that it says that it's unlicensed indication. The reality is that it is given as a benzodiazepine overdose in practice. And it's also the only correct option in this case. So don't be fooled by the unlicensed action in this case. It is the appropriate drug to give. Yeah, that's that question. And we've got a last question for today, also a psychiatry question. You can tell that I'm working in psychiatry at the moment. We've got a 32-year-old gentleman. He's got schizophrenia, so he's been studied in clozapine, unfortunately. He doesn't have any allergies. Now, my question would be, what monitoring should this patient have at 6 months? I'll give you guys 1 minute. I'm sorry, there's a lot to read in the questions. Okay, 20 more seconds. You want me to lock in an answer if you know? Time pressure. Have a bit of a split between D and E at the moment, or the split becomes, or more of a split now between A, B, C as well. All right, let's keep it at that. So again, I know this is quite a confusing question because you have to read a lot of words in a very quick amount. Correct answer would be D. So lipids and weight, I think lipids are in all of the answers, so just ignore lipids anyway. That's the correct answer. So yeah, lipids and weight are commonly measured in most antipsychotics because the patients will put on and will have abnormal metabolism of that. Fasting blood glucose as well. Full blood count in clozapine, of course, is quite important. And prolactin is commonly measured in most antipsychotics as well. Now, I know that if you click on the BNF and you click on the monitoring requirement of clozapine itself, it will come up with this big section. So unfortunately, you're just going to have to read through all of that and try and process as much information as you can in a very short amount of time, which the majority of you did actually get right. So well done for that. So it says here that, for example, you should monitor prolactin concentration at 6 months and then yearly. You should have blood counts, things like that. I think I've cropped it off, unfortunately, in this case. But essentially, it will say that all of the ones previously should have been monitored at 6 months. UNEs, I think, if I remember correctly, are not routinely monitored, making this correction incorrect. It says under hepatic manner to monitor liver function. I think, if I remember correctly, it says to monitor liver function if they have a hepatic impairment. Can double check that though, definitely. But yeah, you're right. If that was the case, then E would be most correct, definitely. Yeah. And just read it carefully. I think that's the most common takeaway from this message. I hope for you guys' sake that this is not a question that comes up from the format, at least, because it's a bit confusing. I think well worth knowing that antipsychotics have a lot of monitoring requirements anyway. So it's worth knowing that they often impact your glucose metabolism. So often people with schizophrenia will go on to have diabetes. They will also continue to put on weight and have hypercholesterolemia. Full blood count is, of course, very important in clozapine specifically because of the risk of agranulocytosis. And prolactin, again, very important in all antipsychotics anyway. So, that was our last question. Now, if there's any questions, I'm happy to answer and go back. We've got around 5 minutes or so. We've got a feedback form as well. I'd be really grateful. You can either scan the QR code on the side or click on the link as well. It will take you straight through. It will take less than a minute, I promise. And you guys can give us some valuable feedback on what you would like to be covered as well. And then if you have more time and more energy, you can fill out the survey link on the left side as well. Yeah, thank you for coming. Again, any questions, please let us know. I'll just go through the chat, and I think most of it hopefully should have been covered. Yeah, you can see a thumbs up from Aaron. Yeah, so we've covered that with SSRI. We've covered, yeah, perfect. Yeah, and yeah, with the SSRI, I do apologize that it also causes QTC prolongation. Should have maybe made it a bit less confusing for a first question.
So for the drug compatibility checker, it'll be location dependent. So some universities and trusts, when you take the PSA, will allow you to have the BNF and or medicines complete, so you can have both of them. But some units or some test locations will just let you have just the BNF. As of, I believe, this year, it's the online only BNF. At least it was in Liverpool.
Last year as well.
I know.
Last year as well.
There were a couple of disappointed people who came in with paper BNFs ready to flick the physical Appendix 1, but they were told, please leave your paper BNF outside and use the Control F Appendix 1. I would say just get familiar with one, get really familiar with either the BNF. Essentially, if you want to play it safe, the BNF is the one that you should get comfortable with, and that's the one that I chose. I know some people were really good at doing medicine complete, but it'll just depend on when or where you're sitting the exam.
Yeah, I think it's a safer bet to go with BNF for that reason. Theoretically, you should be allowed the medicines complete, so that's what they say when you prepare to the PSA, but I'm aware of some people not having been able to access it. No, as far as I'm aware, all of the interaction checker and drug compatibility checkers are not available on the BNF. The other benefit of the medicines complete that I found is a lot more structured. I find the layout a lot more accessible to me. But yes, unfortunately, it's a little bit confusing in terms of what things they do. So my advice would be to, if you're happy to use the BNF, that's absolutely fine. Just go with that. You can also practice if medicine's complete. How do we access medicine complete? So my university gave me an account via OpenAFMS or Shibu or whatever I think you have, and you can log in with that. You can also log in if you have an NHS account. You can also log in with your NHS email as well. If you write the BNF, when you write the PSA itself, there will be in the top corner, there will be a link to the BNF and the medicines complete as well, and that will take you through there. So on the exam day itself, you're not going to need an account to open medicines complete. However, you can do that as well. Yeah, thanks, Aaron. Summarized it well. If you do the PSA, so I know that the official PSA website has some practice papers. You can look at that and then access the BNF from that and see how that works. I think that's quite a good way of seeing how it will actually be in the exam. And I think the other thing that we talked about earlier was how to use the split screen as well. So some people prefer to use the split screen because you're going to have to swap from the exam page, which is a tab, to the BNF / medicine complete. So some people prefer to use a split screen. Some people prefer to switch tabs. Either way is absolutely fine. I just ended up switching tabs because I found that a lot easier, and I found that having the information up big was easier for me. But if you don't want to switch tabs, maybe split screens works fine either way. I think try and see which way is best for you, and then just stick with that. And thank you, Rebecca, for that. Aaron, do you want to take that medicines complete answer that was posted just now? Because I know that you were the one that said that.
Yeah, so I think so. At the University of Liverpool, we had access to both the BNF and Meds. However, during the exam briefings that we just got in the lead up to, we were strongly advised to practice with the BNF because sometimes medicines complete, whilst useful, won't load or would crash. I know of some universities, some other universities, but obviously I didn't study there, that recommended just the BNF, and they would just mandate one side PSA, one side BNF. Yeah, I mean, in my experience, I just got used to the BNF. So, and in terms of how you access multiple tabs, again, that will be down to your exam location. We were allowed to have a split screen. So I personally had like half of my screen PSA, then the other half as a Google Chrome with multiple tabs on the BNF with each one preloaded. I guess as long as you're not Googling things.
Yeah. I think theoretically we would have been able to Google things technically, because I don't think, as far as I'm aware, there was no firewall restriction on ours, so you could just open up tabs. It was quite literally like using your computer like you are now. You could use enough tabs, but I suspect that certain locations might have restrictions on that. But it is essentially, you can imagine it just using like your computer now and opening a tab. And then there was a question of how long did you study for it? I think, again, this is very different from person to person and how much time you want to spend on it. I would recommend, I think I did around 2 weeks of fairly relaxed studying for it, I would say. I'm not the kind of person who likes to leave things to the last minute, but I did find that I was running out of questions to do. So I think you can do it in shorter times as well. But I would definitely recommend loads of practice questions, as many as you can do, and doing it under time pressure as well. You don't have to do the entire exam every time, but practicing maybe each section under time pressure, I think, is very important, so that you know where your strengths are as well and how you can split it. I don't know, Aaron, what would you recommend, anything in terms of how long to study for it?
So, like yourself, I only spent a couple of weeks on it, and the majority I would just essentially I went into it just knowing that I'd done enough placement, and because I was studying for the MLA and the PSA at the same time, there's crossover. So one of the things that will stand you in good stead for the PSA that I found was just having clinical experience, because a lot of the questions, like the SSRI question that was at the start, need a bit of clinical judgment. So, and I think that's one of the things that the PSA is trying to get at, which is why they've got like examination findings, and they won't tell you the diagnosis. They'll just, or they'll give you lab results, but they won't take the next step, because that's for you to interpret that they've got a new AKI and they should stop these medications, which is really similar to what it was in FY1. Yeah, so like yourself, I only spent a couple of weeks, and in terms of the resources, I just did a load of questions. I did my, I think, not to promote, but in my personal experience, I was subscribed to QuesMed. Again, I'm not sponsored. I've got to make that clear. I did all of the PSA questions. We also did the mock PSA questions as well, and I attended a couple of these sessions as well, just to really get my. So when I attended these sessions, I kind of just used the discussion bit, trying to get in the head of one of the presenting doctors to see how they would think about the question. Another thing that I think was asked previously, further up on the chat, was will they give you, essentially when a question asks for you to pick 2 drugs, or which 3 mistakes there will be. There will be 3 mistakes, and there will only be 3 mistakes. There won't be 5 mistakes, and then you'll have to pick the worst 3. That would be really hard. So
they should make it fairly obvious. you know, in disclaimer, I wrote these questions myself. They are not up to PSA standard. They're meant to give you an idea of what the questions are. I tried to match them as close as I can. But if there's an error, for example, like there was with the subtooling question, it should be, it will be obvious to you, and it will be very clear. In terms of the resources I used, so I would start by using the mock papers on the PSA page. There was also a book called Pass the PSA. I had access to a free PDF version that was given to me by my medical school, which I found quite informative. I was using the PassMed questions. I think they're okay for the PSA, just to, if you have time and if you have PassMed anyway, you might as well do those questions. They give you a little bit of an overview and a bit of a practice. And then one that I would recommend, you can also ask other doctors to see if they've got any questions or any resources like these have. The one resource that I would recommend if you can afford it is the British Pharmacology Association. They have some mock papers. I believe you get 2 half papers and 1 full paper or something around that for 40 quid. So it is spendy, but we ended up sharing that resource with, I think, 8 people at least. So if you find a lot of people to share it with, it becomes very affordable. And those papers, I found that they matched the level of difficulty that was in the PSA the best. Because the mock PSA that's on the PSA website is quite easy. It doesn't really compare to the difficulty. So that would be my recommendation. Awesome. Right. I don't think there's any more questions. Yes. So the next session, well, I think it's on Saturday, isn't it? Saturday? I thought it was Saturday, 25th. Yeah. It is on Saturday because we are well aware that we wanted to get 4 sessions in before the PSA, basically. So we didn't want to do it this Thursday because some of you will have the PSA on Thursday. So as a kind of bit of an exception to the rule, we're going to have a session this Saturday at 11 a.m. It's our last session for the PSA. If you can join, please do. But it will be recorded as well. So if you have plans for Saturday, enjoy them and just watching and recording. And then in terms of after that, we'll take a quick break and then we'll start our Road to Finals series as well. So if you follow us on Instagram or anything, we'll keep you guys updated there in terms of how many sessions we're going to do. So yeah. Gonna give 1 more minute and see if any questions, but yeah, feel free to leave. Enjoy the rest of your evening. Yeah. No worries. It was my pleasure. All right. I'm gonna stop presenting now.